Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Today I'm joined by Dennis Watson, Senior Research Scientist with Chestnut Health Systems. This is Dennis's third appearance before these microphones, a new Catalyst record. Welcome and congratulations, Dennis.
Thanks for having me.
I should say that Mike Dennis has been on twice. I believe he's the only two-time guest, so this is a particularly impressive feat.
Well, there you go. Now, no one else can be invited on to beat the record. It's got to stay this way. Yeah,
Oh, is that those are
that
the
that's
rules?
how it works. No. You'll just have to have me back if anyone else hits three.
Yes, okay, that
So,
absolutely. But
yep,
you're lapping the field, so you should feel
yes.
very, very good about this. The first time we
Or
were
you could
on,
just count Mike Dennis and Dennis Watson as one person, and then we're both winning.
we can do that. We can do that. We'll see what the East German judge has to say about that. Anyway, thanks again for taking the time, Dennis. I really do appreciate this. The first time you were on, we spoke about the MetroLink system, that whole program, which is amazing. And the second time we spoke about peer support. Today we're going to speak about Recovery Management Checkups, RMC. So the first question I have is, what are recovery management checkups?
Yeah, so recovery management checkups are a intervention developed by Chestnut Health Systems about 25 years ago. It is a proactive chronic care model designed to help people who have a substance use disorder stay engaged in treatment and also stay engaged in their recovery over time. So the goal is to link people to treatment and keep supporting them because we want to approach a substance use disorder as a chronic disease, which it is, and the way we look at other chronic diseases like diabetes and cancer and support people long term through that. We have a acronym that we have recently started to use to sort of highlight the key aspects of the model. We call it lift up. So it's L for linkage to needed services, for the use of inspirational and motivational engagement techniques. Then we have F, regular follow-ups or checkups. And then T is assistance with treatment connections, and U, unwavering ongoing support. And then the final one, P, is proactive relinkage. So if someone disengages, we want to get them back into treatment as soon as possible. We engage people through regular contact, but we have formalized quarterly checkups that we do with them over the course of about a minimum, ideally, of 12 months. Yeah, like I said, it's been around for 2 decades, and we've had 6 randomized clinical trials and some quasi-experimental studies that have consistently showed that it is effective at initiating treatment, improving treatment exposure, reducing substance use, improving days of abstinence, pretty much all the outcomes we've looked at.
Excellent. So let me ask you, how does RMC align with how substance use disorders should be treated?
Yeah, so like I said, substance use disorders are a chronic illness and they have periods of remission and recurrence. People like to say that recurrence is the rule, right? And so we don't want to just treat it like it's an acute problem where we're going to connect to people to a single episode of treatment because that doesn't necessarily work in the long run. So best practice would say that we should be doing longitudinal monitoring of individuals. We should be striving to identify symptoms when they are returning early, and that we should rapidly get them back into care as soon as possible to prevent any longer term harm. And so, again, this is very similar to how we'd want to treat something like diabetes or hypertension. And, this intervention does that through providing structured checkups, motivational support, and relinkage. It's relatively, if you think about it, the time spent is relatively low. It's a quarterly checkup and then in between some touching base with people to keep them engaged. And it really aligns with contemporary clinical guidance. The American Society for Addiction Medicine has a new focus on long-term recovery monitoring, and they have actually mentioned recovery management checkups as an intervention that fits with that model of or continuum of care for treatment.
Some of your more recent work is focused on RMC in primary care settings. How is RMC for primary care different from the original model?
Yeah, so RMC for primary care, or RMC-PC, as we call it, adapts the original RMC model to operate within primary care workflows. So we've done this research at federally qualified health centers. And while those core elements I talked about with the lift up, they still are there. Really, what we're trying to do is make sure that we're adapting those to identify patients and follow them in primary care. So this would also involve making sure that we're coordinating with on-site behavioral health teams, leveraging the existing referral networks. If a primary care provider has current substance abuse treatment, we would want to do internal referrals, where our intervention has largely been focused on external referrals within our studies that we've done. And we want to also make sure that we're identifying and giving information about physical health issues back to the clinical care team, that we're, not just ignoring that or telling the patient to go back, but that there's a proactive information that's going back to the clinical care team about their physical health issues. The other thing that is, I think, key about it, and where the work with RMC-PC came from, is typically within primary care and other healthcare environments, the way that it's a best practice to conduct screening for substance use disorders on an annual basis and at new intakes. And then if you identify a problem, the idea is that you would then refer those individuals you would give them a brief intervention, then you refer them to treatment. And that's something called SBIRT. So screening, brief intervention, referral to treatment. It's best practice and it's recommended for care to do that in all primary care settings. It is not happening in the real world. And when it is happening, research has shown that it is not effective at actually getting people to follow through with that referral in most cases. And so recovery management checkups within a primary care setting specifically helps to address that gap by providing a more active referral, follow-up, and engagement process for the
Yeah.
patient themselves.
I do want to talk to you about a recent study about RMPC and some findings that stood out, maybe some things that surprised you. You mentioned that RMC has been around for over 2 decades, but RMC-PC is relatively newer. What has been the adoption thus far?
Yeah, so RMC as a model itself has really not been fully replicated outside of the clinical trials we've done. We have, out of Chestnut, done more limited versions of it in practice. Truthfully, under current funding models, it is not something that is easily reimbursed or funded. But, our data actually show that there is a large cost effectiveness to the model over time. So the goal that, one of the goals we have in our future work is convincing payers that this is a worthwhile thing for them, because it should lower the costs. And it actually has societal benefits to it too, because along with reducing substance use, you're reducing things like criminal justice involvement, right? That's a cost to taxpayers. You're reducing emergency room utilization, which those costs get passed on to the rest of us who utilize healthcare. So there's a whole bunch of, other than the direct care provision that person's receiving, that is less expensive. So it has not been uptaken outside of our clinical studies. We have done a small pilot that was after the clinical trial you mentioned, which I can talk about that trial and what we found more if you'd like. But we did a small feasibility trial where we just went into an FQHC and we had one of their staff learn how to do the model, and we compared them delivering it to just a handful of patients. We only randomized about 16 patients to either get half of them to get the services from the FQHC staff person who'd been trained, and half to get it from a staff person in our office remotely.
Mm.
And what we found was that, while there was a learning curve and there are these barriers, that once that staff member had been trained, they were able to manage their regular duties alongside doing the RMC workflow, and that they were able to do it pretty strongly compared to ours. Again, very small sample,
Right.
very small study, but it told us a lot, and it also helped us to identify some of the barriers that exist related to putting this in practice, like the electronic health record. It's a big barrier. Whether or not they have screening already in place, it's a barrier, because we have to work with them to get that in place if it's not there. And if it is there, we have to figure out how are we going to feed from that screening into the intervention.
You mentioned there's a bit of a learning curve in the training. So what does the training entail? What does the training look like?
Yeah, so we are working on that for the real world right now. We know what the research training looks like. We currently are funded through a study through the National Institute on Drug Abuse, their Justice Community Overdose Innovation Network, sorry. We are funded to do our first implementation study of this in the real world, where we're actually going to train other organizations to do RMC. And what we're figuring out at this point is what is all of the training that needs to be done, but also how can we develop this training to be scalable. And so there's basic training just in what is the model, right? Like what is this? What are the procedures? How do you use the tools that we have in place? But then a huge component of our model is, like I said before, the motivational techniques, right? That's motivational interviewing. And motivational interviewing is one of those things within the behavioral health field that everybody is trained to do, but very few people do it well. And
What
our
does it take? What
folks,
does it take to do well
what does it
in your
take to do well?
estimation or in your
I'm not an expert in that specifically, so I wish I had our trainer here who is an expert. See, it's so important we have to farm it out to people who are expert in this, but there is a certification for people who do training in this called MINT certification. And it is really recognizing how to take the cues and work with the patient or the client, whatever you term you want to use, work with them where they're at and not push them, and really roll with resistance, and to be effective in creating change talk with that individual so that they are the ones who are identifying discrepancies and dissonance in their thinking, and then making realizations that lead to setting new goals and behavior changes.
yeah, that
Um,
seems to be again, from an outsider looking in, a difficult thing to inculcate. It seems that's more like an experiential thing. You become good at it by doing it.
You do. And that is why, like, I have been through the training umpteen times and I am not good at it because I do not do clinical practice. I do not use that every day. Intellectually, I get it, makes great sense, but you really do have to practice. Now, I've seen some people who are naturals that just glom onto it because it's just comfortable for them. But what we've seen is that, pretty much anyone can be trained how to do it. It just involves a lot of intensive coaching and training that is not really easily scalable at low cost. We're trying to change that in our current work by utilizing technology that would allow us to improve that model. So, for instance, in your typical coaching, you would record yourself in a lot of the ways this is done. You record yourself delivering motivational interviewing to someone, and you send the recording in. It might take 2 weeks for someone to review that and then get back to you to coach you through what was right, what was wrong, what did you do well, what didn't you do. There's a huge gap between the actual application and getting the feedback, right? Which weakens that feedback. What we're working on right now for this current study is developing an AI that can actually give real-time feedback and training it to give that feedback so that it maps onto what our coach would give.
Interesting. Thus far, again, we referred to this study. Any other salient findings? I know it's still very much early stages. Anything that surprised you, whether that's a positive surprise or something that's like, oh, didn't expect to see this. We're going to need to do more work and refine this component of it.
Yeah, nothing that was really shocking. So a lot of this work was actually carried, when I was making my transition to Chestnut, and so I really got in on the tail end as I was learning about the intervention, and so this was something that was really amazing to me as someone who was learning about it and seeing the data analysis coming in real time, right? Just how strong the outcomes were. So what we saw from the study was that we had more people. So I want to take a step back and say these were, 266 primary care patients at four federally qualified health centers. And they were randomized to either get the SBIRT, the screening, brief intervention, referral to treatment by itself, or they were randomized to get the SBIRT plus RMC. And those in the SBIRT plus RMC group, they were connected to treatment at a higher rate. They were connected to treatment faster. They also had more days of treatment over time. They had more days of abstinence and they had fewer days of alcohol and drug use. Sorry, yeah, fewer days of alcohol and drug use when we cut it across different alcohol and drugs. So really there was an overall benefit with all of the outcomes that we were looking at. I think, as someone who was getting brought into this, who's now trying to figure out how do we implement this in the real world, this is a really amazing, it's both a how to say this, it's a shame that this intervention hasn't been out in the world, right? But it's also a huge, interesting opportunity to me as someone who is interested in implementation and how we get things into the world because it's a really interesting question of how do we build a strategy that can do this and can get it out there to people. And this intervention is not alone in this fact. I mean, the often quoted time is like it takes 17 years on average for an intervention to go from sort of like it works to actually being used in practice.
I was going to ask you for a rough ETA when this will actually be out in the wild. So
Hopefully, we will start training our first organizations. It'll still be part of a research study, but we'd be training our organizations next year. But we are working with several organizations, and we're forming a board of experts to help us figure out how can this be financed, in not just in Illinois where we are, but also in other states. And we are also that's the justice focused study, right? But we're also looking to see if we can move the primary care work forward as well in a similar way.
yeah, it also seems to me that you don't want to be a victim of your success to the extent that you need to make sure that it's scalable on the implementation side and on the training side.
Yeah, and that's exactly what we're doing with the training. Like I said, we're trying to use AI, we're trying to develop tools, dashboards that give real-time feedback that we realize too, we're going to have to train the people who are supervising. We call them linkage managers who deliver the intervention. We have to train them how to give the feedback and how to monitor and to make sure people stay on course because that's all been done within research processes prior to this, right? And as researchers, like we are very concerned with making sure that fidelity is happening. We want it highly controlled to make sure that the intervention is running as planned. Drift can happen in the real world because there's other priorities. And so if we don't train the supervisors how to be aware of that and prepare them for things like turnover, right? We spend a ton of time training someone in how to do this, and then they find another job, right?
Right.
And maybe they found that other job because the training we gave them made them a desirable. So how do
Right.
we sustain that without putting a huge amount of
Right.
cost to retrain every single person who comes
Right.
back in?
Right. You see that in sports all the time. A guy's on the last year of a contract, plays great, and then all of a sudden the organization that gave him the opportunity can't really benefit because the guy's not out in the market and he gets signed by another team. So yeah, that happens. It's kind of interesting. This is probably a different conversation. You mentioned how you're going to be using AI. And it's so interesting when you bring up AI to people in this space. Hate to overgeneralize, but I'm going to overgeneralize anyway. People oftentimes have a knee-jerk response to AI because they have a very narrow conception of it, but they don't realize that at this point, it's part of the plumbing of so much of what we do, of what you do. It's baked in, it's integrated into it. It's not all Gen AI, it's not all Chat GPT. AI can be used in a variety of very creative, innovative ways too, as you're saying, tweak the training and figure out what you need to do to improve it in real time, etc. Speaking of, I don't want to move on to another topic if we
But
have
well,
not completely exhausted this. So if there are any other things you want to talk about, because I do want to just ask, because I know you got your hands in a bunch of things. You're not just doing one thing, you're working in parallel fashion. So I want to know what else you're working on without getting into a completely other conversation and without necessarily teeing you up for the fourth time coming on, because I think that would get a lot of your colleagues very unsettled.
well, I just want to go back to the AI thing and say we're not using it as a complete replacement for the coach. The coach is still involved, and the coach has been involved in helping us to train the AI, right? We are looking to
It's more like a
really
feedback loop kind of
use it as
thing.
an adjunct to the coach, but there's folks will still be getting the in-person coaching. It's just that they will have this other opportunity to engage in get feedback when the coach is not available that could
Right.
accelerate their skills.
Yeah, that
Yeah.
that that was my inference
Yeah.
from what you said. So anything else we want to talk about? RMC, or do you want to now just sort of touch on some of the other projects that you're working on?
I think we talked in the last one, I believe, about so
We
I
spoke
have
about
one
peer
other
support.
we spoke about peer support. I have a peer support project. I think we touched on it in the last one, but I don't know if we've gone into detail on it. That project is now moving into its pilot phase. So we've gone from design to pilot. And then hopefully, if the pilot's successful, we will move to a full scale clinical trial. We do have a funding mechanism that allows for that transition if we're successful at certain milestones. So the study itself, and again, sorry, I can't remember what we did talk about in detail in the last one, but it's developing a workforce intervention for peer support specialists who deliver harm reduction as a service, and specifically thinking about, peers oftentimes they have high job satisfaction. They really are committed to what they do, but they do experience burnout for all sorts of reasons. Harm reduction workers the same way. And then peers themselves, oftentimes certified peers, oftentimes are not always fully trained or prepared to deliver harm reduction. They oftentimes are trained to give out resources, right? They're trained to point people to the syringe exchange or to give them Narcan or test strips, but they're not really trained in the full breadth and philosophy of what harm reduction is. And it's a lot more than that. It's a way of engaging with people. It's a way of structuring your services. It's helping to help people develop plans to mitigate drug risks in any part of their life that might be appropriate. And so we're really working with them to not only to learn that breadth of what can be done and how to use that, but also to think about that some peers, when they're asked to go beyond just handing out Narcan, for instance, that they might struggle with that because they've gone through an abstinence-based recovery, and anything that involves a step beyond just giving an overdose prevention may feel like they're enabling someone because that's what they've been trained, or they may have moral objections to that. So it's really helping them to understand the philosophy that undergirds harm reduction and how that goes beyond just the things that they may have been limited in exposure to.
We are coming into the last leg of a rather challenging year. I think we can all agree that that's a fair description. So I'm going to give you an opportunity to be positive, to wax positive about the coming year. Anything that you see, some signs of positivity, some glimmers of hope, some green shoots.
Yeah, I think I'll start with the negative, but turn it into a positive. So
Okay, fair enough.
there's been a lot of confusion around things like harm reduction and lived experience and different policies that are coming out that conflict with each other from certain places. But I do feel like the positives being that there does seem to be an overall commitment to supporting recovery. There does seem to be a commitment to supporting overdose prevention in the government right now. And I think that if that holds strong, that hopefully we will see, if not things sustaining, like they have been improving over the past few years. Hopefully they at least sustain, if not continue to improve. But, hopefully we don't see too much deterioration due to any sort of confusion about what these policies mean and how they should be followed.
I have to end by telling you I'm a little bit torn. On the one hand, to be fair to your colleagues, I kind of feel that we should put a little bit of a moratorium on these appearances, but you're doing so much interesting work. I don't know if I can do that. I may have to have you back on for a full time sooner than later. But kidding aside, Dennis, as usual, thanks so much. Great conversation. You're doing great work and looking forward to seeing how some of these things coalesce and how they are finally let loose in the real world.
Yeah. Well, thanks for having me. Appreciate it.
Thank you, Dennis. Today I spoke with Dennis Watson, Senior Research Scientist with Chestnut Health Systems. This was his third, count it, third time on this podcast. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.